Neha will introduce you and we'll start.
Okay, great.
So,
Yes, ma'am, we are good to go.
all
Hi
right.
friends, I'm Dr. Bhargav, and it's a great pleasure that Dr. Neha Rastogi, who is a wonderful infectious disease and revolutionizing the way we look at the infections in this country, has curated this program for you for Infectious Disease Forum in an immunocompromised patients. And today's topic is, of course, none other than the intricacies of managing the fungal infections in an immunocompromised patients. Because we know from past 1 decade, we have been able to get some handle of people suffering from blood and blood cancers, and the majority of time the cause of death or the morbidity was fungal infection. Then came the posaconazole, and we started getting less and less, but still it's a major problem, not only in diagnosis but also in treatment. And we have got none other than Dr. Neil Stone, who has gracefully accepted this invitation to talk to us in next 35-40 minutes across the length and breadth of the continents and across the world to teach us about invasive fungal infection. So I congratulate Dr. Neha again for this wonderful session and wish her all the best and bring the changes of what we discussed today in the clinical practice. Over to Dr. Neha.
Thank you, Dr. Rahul. And hello, everyone out there. So, this is session number 3 in the series as we discussed about the Infectious Disease Forum in Immunocompromised. So, we spoke about viral at length, but one infection which is really, really emerging, and like we say, we are all omnipresent. One infection which is so omnipresent is fungal infection. You talk about the hematopoietic stem cell transplant, you talk about the hemat malignancy. Even if you talk about in the terms of relatively immunocompromised, I would say that is uncontrolled diabetes, critically ill patients, a lot of gastrointestinal issues. Fungal is one word which is kind of linked with everyone and everywhere. So we have none other than our very, very famous Dr. Neil Stone. So I call him as a fungal guy, I would say, that he's going to talk about in next 30-35 minutes. And of course, followed by the important questions which we are able to look answers and more insight from Sir in the invasive fungal infection exclusively in the immunocompromised host. Sir, though needs no introduction, but he is working as a consultant ID at the University College London Hospitals. One very important, connect I could find out is that he leads the mycology and hemato-oncology license and is the coordinator main in the Brit MIC network. As we know that he is focusing mainly on the invasive fungal infection, and one very important research topic for him is also the combination antifungal therapy for the invasive Candida auris infections. So without wasting a further ado, I would really, really invite you, Dr. Neil, to give us a wonderful insights on this fungal infections with a fun-loving guy like you. So over to you, sir. Yeah.
Thank you so much. And what a great pleasure to be invited. Let me just try and share my screen and make sure that's working before I start to talk. Okay, let's see if I can get this to work. Okay. Let me share my screen. Can you see that? Okay. All right. And hopefully there might even be a moving image you can see if it's coming across properly. Okay, am I good to go? You can see it okay?
Yes, sir.
And I'm going to move, it moves forward. I'm just checking. Okay, great. So we'll get going. So firstly, thank you so much for inviting me, Dr. Neha. It's a great pleasure to be working and talking with colleagues in India. I have to say, I've never worked in India, but I've been very lucky. I've visited India several times, and I've always greatly enjoyed my visits to your amazing country with all its variety and complexity. And I would love to work with colleagues in India going forward. So I'm going to talk to you about my favorite topic, which is, of course, fungal infection, and really just give you like a brief overview of some of the many challenges that we face really at every level when managing these very difficult fungal infections. So fungi are important and they're deadly, and I think I'm probably preaching to the converted of people who already do understand this, that fungal infections are important. So this is a quote which stayed with me from an American mycologist 2005, who said, fungi are the interface organisms of life and death, which is quite profound, I think. And if you think about in nature, fungi are often decomposers. So they will carry off things like dead fruit or compost and actually cause decomposition, which is pretty horrible. And unfortunately, as you know, we do see this in patients as well. And we see these very awful infections like mucormycosis, which India is probably the world center of mucormycosis. You see more cases than anywhere else in the world. And these are obviously devastating and horrific, life-threatening infections. And despite that, every time I mention to people, even doctors, not just people who are in the lay community, that I specialize in fungal infections, they immediately think of nail infections or skin infections, which is something trivial or unimportant. But I'm sure everyone in this call knows how important these are. And the death toll of fungal infections is absolutely massive. So in our field of ID, we talk about the big three, that's TB, HIV, and malaria, and they get all the funding and all the research, and everyone knows about all these infections, but fungal infections are largely ignored. However, and I had to update this slide recently because new data has come out, fungal infections actually cause the deaths of something like 3.8 million people every year. That's double the number of patients who die from TB, and I know, again, India has a very high burden of TB. And certainly more than malaria. There is some malaria still in India, predominantly affects sub-Saharan Africa, but fungal infections kill many, many times the number of people who die of malaria. And despite that, it gets a fraction of the research funding and the awareness out there. So there's an old joke about mushrooms. Why is the mushroom always invited to parties? Because he's a fun guy. So it might be a joke, but actually it's the opposite. Mushrooms or fungi are not invited to the party, they're forgotten. And that was a perfect example of this was in 2017 when the WHO published a priority pathogen list. They were all bacteria. They were all bacteria. Fungi were completely forgotten, which is quite typical of mycology being a neglected specialty. Fortunately, that's been redressed recently, just in November of 2022. And you might have seen this WHO fungal priority pathogens list. And this has actually been really important to raise awareness and set the research agenda for these most important fungal infections. And you can see in the critical group here, got Cryptococcus neoformans, Candida auris, which of course is a huge issue, Aspergillus fumigatus, and Candida albicans, because they're the most common. So I'm going to go through some of the challenges really that we see in mycology all over the world. And there are challenges at every stage in the journey when we're trying to manage fungal infections, everything from diagnostics, the lack of antifungals, the effect of climate change on fungal infections, emerging resistance is clearly important, new emerging species, and some of the surprises we saw following COVID-19, which I'm sure you all experienced. So let's think about diagnostics, and this is absolutely critical because nothing happens without diagnostics. That's the start point of everything. And I'm sure yourselves, just like we do, we really struggle with diagnostics for invasive fungal infection, particularly in the immunocompromised population, patients who are perhaps neutropenic. So we know that the gold standard diagnostic for invasive aspergillosis, and it's aspergillosis that we worry about most, certainly in our setting in patients who are neutropenic or undergoing stem cell transplants, we worry about aspergillosis. The only way to diagnose a proven case is with histopathology, because the hallmark of invasive aspergillosis is angioinvasion. It has to invade through the blood vessels. It's not even enough to see it or culture it, because we know airways, for example, can be colonized. It doesn't cause invasive infection. We need to see hyphae invading through the blood vessels. So if you can see here, this is a case we had of invasive aspergillus sinusitis. If you screen out a little bit or zoom out, you can see there the vessel wall. That's the white strip. That's the blood vessel wall. And you can see the fungal hyphae going through the vessel wall. So that's angioinvasion, and that's a proven case of aspergillus. We know this is aspergillus probably because it's got thin hyphae which branch off at acute angles and they're septated, as opposed to mucor, which would be thick with right angle branching hyphae and would have no septate. The reality is we almost never get this. So of course, to get a biopsy is an invasive sample. It's not simple. And histopathology might take 2 weeks to come back. And these are critically ill patients, and we do not have that kind of time to wait. So we're relying increasingly on biomarkers. And this is something which will be familiar to you, but it causes quite a lot of confusion in terms of how to best use these tests. So this is the fungal cell wall. And one of the things you'll notice first is probably these green cross-linked chains. These are beta-glucan chains, and that's what we're looking for in the beta-D-glucan test. That's present in most fungi, particularly Candida, Aspergillus, Pneumocystis, for example. Then we've got the manna protein, such as galactomannan, and that's much more specific to Aspergillus in particular. So that won't be positive in, say, Candida or PCP. This is how the beta-D-glucan test was derived. Believe it or not, these are Atlantic horseshoe crabs, which are bled for their bright blue blood, which coagulate in the presence of environmental fungi. That picture always stays in my head because it's really quite striking and unusual, but this is really how the test was derived. So just to summarize what we're looking for with these tests, so as I mentioned, beta-D-glucan, it'll pick up a range of fungi, Aspergillus, certainly, Candida, PCP, histoplasma, which I know is present in India, Talaromycosis less, so not something we see in our setting. They're non-endemic to us, but we do see imported cases. And galactomannan, certainly in our setting, it's almost always Aspergillus we're looking for. But again, if you're in an area with histoplasma, for example, it might give you a positive beta-D-glucan. Cryptococcosis, beta-D-glucan and galactomannan will not be positive, but of course we've got the cryptococcal antigen, which is a very sensitive and specific test. But unfortunately, mucormycosis, which I'm sure many of you have come across, we don't have any biomarker at all. So it's already difficult to diagnose fungal infection, and mucormycosis is even worse because we don't have any biomarker. So of course, based on that, we have to use other surrogate markers and categorize these into proven, probable, or possible cases. And this is based mainly on the EORTC criteria for mainly invasive aspergillosis. That's the European Organization for the Research and Treatment of Cancer. And it's a combination of risk factors, radiology, and biomarkers. So proven cases I mentioned, that needs to be biopsy proven. We almost never see that, less than 5% in our setting. Probable cases when you have a host with risk factors, which would be your patients in hemato-oncology, for example, a radiological factor, so a CT scan, which is suggestive of invasive fungal infection, and one test, which is positive, perhaps a positive beta-D-glucan. That's a probable case. In reality, and I'm sure your experience is the same, normally we deal only with a possible case, where we have, yes, an at-risk host who's perhaps neutropenic. We have a radiology report, which is very equivocal. Could be fungal, could be parasitic, could be viral. We've all seen those kind of reports. And we have tests which are all negative. So what do we do then? Do we treat or not? The reality is often we do treat because we're worried about the patient. But that, of course, has cost and toxicity. So thinking about radiology, we all learn in the textbooks and talks like I'm giving you now. There's the classic signs of invasive aspergillosis, for example, the halo sign. You can see that's an area of consolidation surrounded by ground glass changes, which is hemorrhage around it, or the air crescent sign when you get a bit of cavitation and air in there. But again, the reality is, and you'll know this, and those who practice in this field, scans rarely look like that. It's usually much more vague, multiple pathologies, presents differently in the immunocompromised. So most of the time we have a very unclear radiology report, which makes these decisions even more difficult. So what about rapid tests? So they're great because they're low tech. They don't need a lot of resources. They're cheap. The best example of that, as I've already mentioned, is the cryptococcal antigen. I studied Cryptococcus in my PhD, and these strips made by IMI are fantastic, very sensitive, very specific, very easy to do. This was one morning. I remember I did 4 lumbar punctures in one day, and I had these strips in my pocket. This was in Tanzania, in East Africa, and 2 were positive and 2 were negative. It's very easy to interpret. It's 2 lines are positive, 1 line is negative. There are more rapid antigen tests coming, and one which may well be of interest to you is the histoplasma urine antigen. I know there are cases of histoplasma dotted around India, and you might see cases occasionally. Historically, certainly in the UK, we've had very poor access to histoplasma diagnostics because we're a non-endemic country, but we do see imported cases in London because we have people from all around the world. We now have access to a rapid urine antigen test, which will give you a result just in a few minutes, really. And it's a non-invasive sample like a urine. We've also got an Aspergillus galactomannan, which is a rapid test now made by the same company. So this is really important in terms of access because particularly smaller labs and rural centres just don't have access to these tests at all. And even bigger centres might send them out and it might take too long to be clinically useful. There are also an increasing number of molecular tests available for various fungal infections, for example. So moving on to candidiasis now, we've got access to a test called the T2MR. So it's essentially a candida PCR in blood. It is expensive, certainly even in the UK, we're the only centre to offer it so far. We actually evaluated it. We found it more useful actually for stopping antifungals, so being a stewardship tool rather than diagnosing candidiasis, but it is a useful addition wherever you can get it. This is our paper. We found that when we had a negative T2MR candida PCR in the blood, we were actually able to stop antifungals in about 30% of the time because we had a negative test rather than finding cases of candidiasis that we would otherwise miss. Other molecular tests we can use in mycology are the 18S PCR test. So this is analogous to the 16S PCR that we use for bacterial DNA. This picks up a conserved region of which is across fungi in a sample, usually a tissue sample, and then we can sequence it out. We do have this available. I would say it sounded great, but in practice it's not revolutionized our management because the pickup rate is actually quite poor. So we've got a deadly disease and we've got limited tests. So how are we going to best manage it? And this is something I think we all struggle with, certainly in infectious diseases, hemato-oncology. How are we going to manage this? And there are several strategies which are employed, which will all be very familiar to you. So of course, there's prophylaxis, and we base that on risk factors. The patients at highest risk of fungal infection, we will often use prophylaxis. For example, patients undergoing a hematopoietic stem cell transplant. We use posaconazole, for example. There's the empirical strategy, and most centers will use this too. This is when you essentially have fevers which are not responsive to antibacterials after, say, 72 or 96 hours. There's also another strategy, which is preemptive treatment. So we've mentioned galactomannan and beta-D-glucan. So what if you don't use prophylaxis, but you do surveillance by doing this test every 2 weeks? And ideally, we want targeted therapy. That's when we have a proven case and we treat. Unfortunately, this is elusive, as I've discussed most of the time, because it's so hard to prove a case. However, there are problems with each and every one of these strategies. Prophylaxis sounds great. We think, well, we just put everyone on POSIT and they won't get fungal infections. But clearly, there are problems with that. It's expensive. We introduce toxicity to the patient. Sometimes we get breakthrough infections. We have drug interactions. Sometimes the patient doesn't like taking so many medications, so it's not perfect. Empirical therapy, I think most centers do use it, but what happens is it results in overuse of antifungals. Because clearly not everyone with a refractory fever has a fungal infection. The preemptive strategy, so surveillance with beta-D-glucan and galactomannan, say twice a week, might work, but as I've just said, well, as I've mentioned earlier, or I've alluded to, I should say, beta-D-glucan and galactomannan don't have great sensitivity and specificity. So can we rely on them, really? And targeted therapy, as I've said, we hardly ever get a case. There have been some data on this, randomized data, for example, in the ICU setting. There was something called the Infectious trial looking at empirical therapy and whether patients on the ICU who had refractory fever were given mycofungin, in this case, had a better outcome, but actually there was no increase in fungal infection-free survival at day 28. So that strategy, which many ICUs use and most hemato-oncology centers use, of just giving an antifungal empirically without proof of disease, didn't actually contribute to better outcomes. Some ICUs also tried beta-D-glucan surveillance. They're particularly worried about candidemia, whereas in the hemato-oncology setting, we'd worry more about aspergillosis. Again, the data on this is varied. It's small numbers. This is one from this is in the United States a few years back. 64 patients on the ICU, and agilafungin was started if the beta-D-glucan test was positive. And we're talking small numbers. 21 of them received treatment. There was only one proven case of invasive candidiasis and 5 probable cases. It was well tolerated, but was it really cost effective? And the ultimate outcomes weren't much better. So the jury is still a little bit out on that. You have to weigh up a number of things, including cost and access to these tests. Thinking about candidiasis, so there are different tools we can use to identify candidiasis. I've mentioned EORTC criteria for aspergillosis. Candidiasis, there are various scores out there. For example, the Candida score or the Ostrowski-Zeichner score, which most places don't really use. I would say clinically, it's more used in research, but essentially it's adding up the risk factors. The risk factors for candidiasis are TPN, surgery, multiple sites being colonized, particularly abdominal surgery or pancreatitis, and you add them up. And unsurprisingly, the more risk factors you have, the greater the score you're going to get. So we've mentioned antifungal prophylaxis in hemato-oncology. So now most centers use it, and most centers use posaconazole. But interestingly, even in the UK, 20% of our centers actually don't use prophylaxis. And as I mentioned, some of the problems with it: cost, drug interactions, toxicity, and driving resistance. So we've actually signed up for this clinical trial, which is a little bit controversial, but let's see what it shows. It's called the BioDrive, Biomarker-Driven Antifungal Stewardship in Acute Leukemia, where our patients with acute leukemia are randomized either to receive standard of care, POSA prophylaxis, or to receive no antifungal prophylaxis, and twice weekly beta-D-glucan and galactomannan surveillance. We are able to do that because we're very lucky that we run beta-D-glucan and galactomannan every day. Many hospitals around the UK don't get a result back for a couple of weeks. Some people were unhappy with this because they don't like the idea of a patient not being on a prophylaxis, but other smaller studies have suggested this is actually a safe way of doing surveillance with all the advantages of not giving prophylaxis in terms of driving and costs and interactions in driving resistance. But we'll wait and see what the result of that is. That's ongoing. So the question is essentially, is a biomarker-based stewardship strategy superior to a prophylactic antifungal strategy in reducing antifungal therapy use in patients with acute leukemia without impacting health-related quality of life at 12 months? And we're recruiting for that at the moment. We know, I mentioned particularly the empirical strategy, we end up overusing antifungals for sure. We're trying to reduce that. So we looked at our data, looking at our AML cohort over the last 3 years or so, 381 patients with acute leukemia. 43% of all those patients got antifungal therapy, not prophylaxis therapy, during their chemotherapy, which is probably not surprising to you who work in that field. Most patients end up getting treated for fungal infection. But actually, as I mentioned, we very rarely get a proven case. Just 3% of cases were proven invasive fungal infection, 6% proven improbable. So that means to us one of two things. Either we're way overusing antifungals and all the problems of cost and toxicity and driving resistance, or our diagnostics are bad. And the answer is it's somewhere in between those two. It's a combination. Okay, so that's the diagnostic challenge, which is really the starting point. What about the therapeutic challenge? What about when we decide, okay, we are going to treat this patient for a fungal infection because it's either proven or we're pretty sure they've got it? As you'll all be aware, we really have a lack of drugs in mycology, either a lack of drugs which exist or a lack of access to them. They do. And this really sums it up. So this is a graph of fungal drug development over the last 60 years. And the fact that I can get it into a single graph tells a story. It's not very impressive, is it? Very few classes of antifungal, very slow development. This is again because of this problem of neglect, lack of investment in research and funding. If you compare this to chemotherapy drugs, or compare this even to antibacterials, it's much, much less. So essentially, we only have 3 classes of antifungals available for clinical use. And these are the polyenes, which you'll be familiar with, so nystatin being the topical version, but amphotericin B or the liposomal formulation, such as ambisome, really being the bedrock and the mainstay of a lot of treatment we use for invasive fungal infection. Then, of course, we've got the echinocandins, which are cell wall agents, caspofungin, anagilofungin, and mycofungin, which are all pretty similar. Very, very good anti-candida drugs, maybe not so good for aspergillus. Then there's the azole class, which as it stands is the only orally available therapy we have for serious fungal infections. Fluconazole, you'll all be familiar with. It's been around for many years, but it only treats yeasts. Then we've got the mold-active azoles, itraconazole, voriconazole, posaconazole, and ibuconazole, and a few others which we use occasionally, such as flucytosine, which we can't use as monotherapy because we develop resistance very quickly. Terbinafine and griseofulvin we mainly reserve for skin and nail infections. So very few drugs to start with. And as you'll know, they all have problems. So if we think about the azoles, there are a number of difficulties with them. So QT interval prolongation is a real problem. Liver function dysfunction, we see that very commonly. We need drug level monitoring, particularly with posaconazole and voriconazole, and that's often not available in hospitals, which is critical because we often see levels which are subtherapeutic. They have a number of drug interactions, particularly with chemotherapy, vincristine being the prime example. There are a lot of very important drug interactions which often patients are not aware of, or even doctors are not aware of. For example, proton pump inhibitors. You need stomach acid to absorb, particularly posaconazole and itraconazole. So if you're on PPI, they will not be absorbed. We do have ivconazole now. Some of you may have access to that. Some places don't. It's the newest azole. It's got several advantages. So we can give it both PO and IV. It shortens the QT interval. It's the only azole that does that. All the others lengthen the QT interval. And it's got a broad spectrum of activity, including Cryptococcus, the dimorphic fungi, Candida, and Aspergillus. It also has got good CNS penetration, which is important when we're worried about fungal infection in the central nervous system. And importantly, we don't need level monitoring, which is a real limiting factor for some of the other azoles. We know this is a good treatment for invasive aspergillosis. So voriconazole is standard of care, but we now have phase 3 data, head-to-head comparison, but ivconazole versus voriconazole, and it was non-inferior. So it works just as well, but has all the advantages I just mentioned if you can access it. It's still costly. That's the limiting factor for the moment. Echinocandins is something we're using increasingly, as I've mentioned already. Caspofungin, mycofungin, and anidulafungin. We now have resafungin. I'll talk a little bit about that later. That's a once weekly echinocandin, which has just been licensed in the UK and the US. And we use that first line for candidemia. It's generally very, very well tolerated, but it can cause liver function test derangement, although anidulafungin is probably worse than the others for that. But it does have important gaps. So don't forget that it's not active against Cryptococcus or Mucorales. So that's also why the beta-D-glucan test will not be positive in those infections, because that's the target site for the echinocandin. So it all fits together. You get a negative beta-D-glucan, and the echinocandins won't work against it. Polyenes you'll be familiar with, as I've mentioned, amphotericin B formulations such as ambisome. It's our broadest spectrum antifungal. It's our backup when we don't quite know what's going on because it's so broad spectrum. It's not first line for most fungal infections, actually neither Aspergillus nor Candida, but it is first line for Cryptococcus and mucormycosis. We'll be aware of its limitations in terms of toxicities, in particular nephrotoxicity, anemia, electrolyte disturbances, and that's because a lot of antifungal drugs, they actually target the cholesterol in the cell membrane of the fungus, which is actually very similar to human cells. So it causes a lot of toxicity to human cells. We're also seeing increasing resistance to antifungals. And that's because of a number of different mechanisms. So we see a lot of classic microbiological mechanisms. So target site mutation, as you might expect, efflux pump upregulation, drug breakdown with enzymes. That's not such a feature in fungal drugs, the way we see in bacteria, for example, with beta-lactamases, and copy number variation and disomy. See, these are very different from bacteria. Fungi are complex eukaryotes with multiple chromosomes, and they have variation in number of chromosomes, which changes. It's very plastic and fluid, and that can lead to resistance. So just looking at the mechanism of actions, this is where the polyenes work here. This is as I said, the ergosterol in the cell membrane. Essentially, it punches holes in the cell membrane and destroys it. So if you get mutations in that target site, that's where you're going to get resistance. There is a problem with amphotericin resistance, maybe not so much as with the others. There are intrinsic resistant species, for example, Aspergillus terreus. Terreus means earth in Latin. It's got this earthy color. And we do see some other species like Scedosporium, Trichosporon, even Candida lusitanii, which can have intrinsically higher MICs to amphotericin B, but not so much of an issue. The echinocandins, as I've mentioned, they're cell wall agents. They work on the FKS1 and 2 genes, which produces beta-glucan synthase, and they block synthesis of the cell wall, and it causes rapid cell death. So I've already mentioned that they don't work against Cryptococcus or the Mucorales, also the Fusarium species, Histoplasma, Geotrichum, and Trichosporin. So there are a number of gaps actually in the spectrum of activity of the echinocandins, which you have to be aware of. That's primary resistance. Secondary resistance is also an important problem. So I showed you the FKS gene, that's the target site. So if you get a mutation in that gene, the drug won't work. And we're seeing that increasingly in particular with Candida glabrata, that if you expose a patient with Candida glabrata infection to long courses of an echinocandin, such as caspofungin, we are seeing development of secondary resistance, particularly in the United States. And this is a graph the early 2000s of the increase in Candida glabrata, which is resistant to echinocandins, and it's going up and up and up, which is a real problem. We already have very few antifungals to start with, so we can ill afford to lose more and more to drug resistance. Flucytosine, which you'll come across probably in combination with amphotericin B for Cryptococcus, we can't use this as monotherapy because it very rapidly develops resistance. This is the pathway of action. It's quite complex, but all you need is a single point mutation anywhere along this pathway, which renders it resistant, and that happens very easily and quickly. So it must only ever be given in combination. The azoles also works on the cell membrane. The target is something called 14A-demethylase produced by the ergolivin gene. That's the mechanism of action. And we're seeing increasing azole resistance through a number of mechanisms. So again, target site mutation. If that ergolivin gene mutates, the drug won't work. Efflux pumps are very important in azoles. You get upregulation of the efflux pump, and it will literally pump the drug out of the cell. And as I mentioned, copy number variations in chromosomes are important. So we're seeing increasing azole resistance. So certainly fluconazole resistance is a problem. One of the newer things we're seeing is, particularly in Southern Europe, is Candida parapsilosis, which was always thought to be reliably susceptible to fluconazole. We're really seeing an increase in resistance, which is something new and unexpected. So that's really on the up and up. And of course, if you get all these mechanisms all together, the FKS1 and 2 mutation, efflux pumps, azole resistance, and polyene resistance, we end up with multi-drug resistant organisms such as, and I can't believe I've not mentioned it up till now, Candida auris. That brings me on to the resistance challenge. So we've spoken about the diagnostic challenge, which is huge because it's hard to diagnose, the therapeutic challenge, because we have few drugs, which are toxic and expensive. And this is all made worse by the resistance challenge because antifungal resistance is growing. And what does the future hold? So I'll come back to Candida auris in a minute. But one of the problems we see is that we're seeing increasing azole-resistant aspergillus. Now, why am I showing you this tulip field? It's quite a beautiful picture. So this is in Holland, the Netherlands. They're very, very famous for their flower industry and selling flowers. They actually use massive amounts of environmental azoles to protect these plants. What happened is we have resistance developing in their environmental aspergillus, which then infects patients who have azole-resistant aspergillosis. And even this morning, just from my local shop, I bought an orange. And actually, if you look carefully, it says treated with imazolo, which is actually an azole antifungal. So this is happening on a massive scale. And we're actually promoting antifungal drug resistance in the environment, in agriculture, before it reaches humans. And this is really an increasing problem. So azole resistance in molds, particularly aspergillus, it's been reported all over the world. In the Netherlands, where it was really best described, up to 20% of their aspergillus is actually resistant to azoles, and voriconazole is first-line therapy. So that's a real clinical problem. And of course, Candida auris, this is a big issue, and I know this is certainly a big issue in India, as it is all over the world. And I've called this the yeast of our worries. It's been described as a creature from the Black Lagoon because it bubbled up and it's now everywhere. And I think that really is the case. So this was only discovered in 2009. It's hard to believe, actually, just 15 years and we didn't even know it existed. It was first discovered in the ear of a patient in Japan. So auris means ear in Latin. That's why it was called that. It's been discovered in the environment, actually in India. But the first place it was discovered environmentally. So it does seem to be an environmental organism. It was actually found in the Andaman Islands, which I believe are very, very beautiful. It was found on one of the beaches there. And it has just exploded. It's spread all over the world. So the countries in red is where it's been described, and the countries in gray are just where there's no data. But I believe it's probably in every country in the world or close to that. And we know that there are certain parts of the world which have a particular problem with Candida, or certainly it is common in India, the Gulf states, so Kuwait, Qatar, Oman, and Dubai, very endemic there. And I know there's a lot of travel between the two and people working in the Gulf, going back and forth from India. And this is a huge issue, which I'm sure you've all come across and is a real concern globally. So in South Africa, for example, so invasive candidiasis, usually Candida auris causes colonization, and it's more of an infection control worry, but the mortality is very high. If it gets in the bloodstream, we're looking at 30% mortality. And actually in South Africa, it's the third most common cause of candidemia, so bloodstream infection in the whole of South Africa, which is quite scary, really. Why has it emerged? Well, we don't really know. So there's a theory, which is a pretty good theory, that it exists in these wetlands and it's environmental. That climate change has led to a slight change in the Earth's surface temperature, and it's slightly changed that delicate microenvironment, which has allowed this fungus to thrive. Perhaps it's been carried by maybe birds or something, or people from rural areas into urban areas, into the hospital setting where it spreads rapidly. None of that's proven, that's speculation, but it seems quite plausible to me. So Candida auris is a real concern. Another issue is the rise of histoplasmosis. Actually, these endemic mycoses, which I've mentioned, these were always thought to be very much confined to places which are pretty hot and humid, including northern parts of India. We do see cases of histoplasma, and certainly Bangladesh. In my practice in London, I've seen several Bangladeshi patients who have come back with histoplasma. You can see here, these areas of purple are expanding, even into Europe now, where we never saw histoplasma before. And that's thought to be, the theory goes, that climate change is causing an increase in the world's temperature, allowing support for these mycosis, which can cause human disease. Another basic issue in antifungal resistance, which again, India is really at the forefront of, is something called trichophyton endotheniae, so terbinafine-resistant dermatophyte. So I said right at the beginning that people who don't work in this field always think of fungal infections as skin infections or nail infections, whereas we worry about the invasive fungal infections. But actually, these skin infections are unpleasant. They might not kill you, but this poor man on the left, that's pretty unpleasant to have. You wouldn't really want it. And it's extremely common. Historically, terbinafine has been very, very effective. and that's been given even without diagnostics, but we've been seeing increasing resistance and the emergence of this terbinafine-resistant dermatophyte. Often needs itraconazole for long courses with the cost and toxicity and levels monitoring that it needs. And it's also difficult to pick up because most places would just treat something like that empirically rather than sending it to the lab. But it's critical we actually get samples in the lab to do PCRs and susceptibility testing and pick up these emerging resistances. And of course, COVID, probably everyone's tired of hearing about COVID, but there's no question it had an impact, of course, on many things, but also on fungal infections. So this was a patient who we had in our ICU, who had a bronchoscopy, and you can see this black necrotic material, and this was a case of COVID-associated pulmonary aspergillosis, and also known as kappa. Certainly, we saw that as quite an issue in the height of the COVID pandemic, which fortunately is behind us. But again, it was a really good example of the interplay between other infections and fungal infections coming through as opportunists that complicate the infection. Move on. You can see those pictures. That's COVID-associated pulmonary aspergillosis, which I dare say you saw some cases of as well. Fortunately, we're seeing very few cases of COVID now in the ICU. Occasionally, we might see this. We just have to remember that. And of course, mucormycosis, as I've mentioned, something you'll know a lot more about myself was the explosion of cases in India all over the country following the COVID pandemic because of this mix of patients getting steroids, uncontrolled diabetes, and I'm sure there's more environmental mucorales in India as compared to the UK. We do see cases here, but not on the scale that you see across India. And I never thought in my life I would see the opening of mucormycosis wards, and there's a couple of examples here. So what does the future hold? So that paints a fairly gloomy picture, but there is some hope on the horizon. So let's think about new antifungals. There are new antifungals coming through, and this is really quite exciting. And they're new in a couple of different ways. So either they're new in terms of formulation, that they can be given oral, whereas we only had an IV formulation, or they have different pharmacokinetics, or they're entirely new mechanism of action. So for example, we've got a drug called fosmanogepix, which is a GWI anchor protein inhibitor. And the key thing about that is that's a completely novel mechanism of action, different from any of the other antifungals we have. So that's exciting. That's in phase 2 and 3 trials. Rezafungin and ibrexafungerp, they're essentially new formulations of the echinocandins. So rezafungin has just been licensed in the UK and the US. That's very similar to, say, caspofungin or inidulafungin, but it lasts for a week. That allows once weekly dosing, which could be very, very useful for some patients. It's approved for treatment. We're doing a trial now of prophylaxis and stem cell transplantation for rezafungin, which really could be helpful for particular patients who can't have azole prophylaxis, can't tolerate amphotericin B, or perhaps live very far away. So once weekly dosing could be very convenient for them. Then we've got this strangely named ibrexafungerp, which is interesting. That's also in late stage clinical trials. That's essentially an oral version of the echinocandins. All the echinocandins we have at present are IV only, so an oral version could be very useful. Then we've got something called olorifim, brand new mechanism of action, completely new. It's a very powerful anti-mold drug. They're very good for aspergillus. We've used it a few times now on compassionate basis, and it's in phase 3 trials. So I think you will be using this in the next few years, although just bear in mind it has no activity against yeasts, no candida activity. There's something called palmicide or opoconazole. That's an azole, which we know about, but this is an inhaled formulation. So particularly important with patients with perhaps tracheobronchial aspergillosis, lung transplant patients, and you get direct delivery of the drug to the lungs by giving it inhaled. So just going through these fosmanogepix, as I've mentioned, this is this new GPI inhibitor. It's very broad spectrum, can be given oral and IV. It's got good CNS and eye penetration in animal models, and I think will be a very interesting drug going forward. Ibrexafungerp, I mentioned, this is the oral echinocandin. Can be given IV if needed, but the beauty of it is that it's an oral formulation. It's got very similar spectrum to the echinocandins with those limitations. So it won't treat, as I've mentioned, crypto or mucor. And its urine and CNS penetration is poor, which is also the case for echinocandins. But I think it will be very, very useful, perhaps as a follow-on therapy for IV from someone with candida infections. And rezafungin, as I mentioned, this is this weekly echinocandin, which we've actually just started using in this country. Inevitably, new drugs start out very expensive, but eventually they become generic and become more available. And I think you'll have access to that in the near future. We have to be very careful, of course. So this is, you don't need to be able to read this. This is the introduction of antibiotics along the top. along the bottom is emergence of resistance. And the message here really is that having new drugs is clearly not just going to be the answer unless we use them properly. If we overuse these drugs, we don't practice good stewardship, they will develop resistance very, very quickly. So there's a real lesson there from this real problem we have that we all know about with antibacterial resistance. So what we can do about all of this, well, antifungal stewardship is absolutely critical. You have to use antifungal drugs wisely, judiciously. Yes, it's limited by difficult diagnostics, which I've discussed. I think greater problems with the resistance, but we have to make sure we use these wisely. Otherwise, again, we end up with a problem like Trichophyton endotinii, where you get terbinafine resistance and a problem for millions of people. And we need a One Health approach. So One Health is this concept that human health, agricultural health, and animal health are completely linked. I think I gave you a perfect example with the agricultural use of azoles. If we don't work with our colleagues in agriculture, if we don't work together, then it doesn't matter what we do in human health, resistance is going to happen in the environment and we're not going to have a chance. So without a One Health approach, we will fail. So I'm going to end there. That's we've got about 15 minutes left for questions. I hope that was useful. I'm aware that was a very brief sweep of the challenges, but I hopefully it laid out all the difficulties we have with diagnosing and treating fungal infection, with a little bit of hope for the future with all these new drugs coming through, but also a warning that we must use them judiciously. Thank you for inviting me again. I hope you've enjoyed the talk, and I would be very happy to take some questions. Thank you very much.
Thank you so much, Dr. Neil. That was indeed very, very enlightening because you practically covered all the aspects, and I would say more and more roadmap to be laid for the future, as you mentioned, for the fungal infection. And we also know, we were talking initially about first from the suspicion, first of all, and then talking about the spectrum, and the next in the line is the susceptibility. So I think all the three comes in a way when it talks about fungal. So just a mention about Trichophyton endotenii, because majority of the times, sir, what we have seen as a ID specialist, when they come, a lot of them uses those skin creams which contain a lot of steroids. So that's why half of them will just go like that. And then when they come, it was more rampant in usage. And then with the over-of-the-counter drugs, the improper doses, the improper duration, that actually leads to a lot of resistance. So moving on, we have a lot of list of questions. So I'll just break it into a very, very short form. So as compared to the first, very important thing is about the diagnostics you have mentioned. Now, how sacrosanct is this galactomannan and beta-D-glucan, especially in the immunocompromised settings when you're already on prophylaxis? Because their value is going to be a very, very changing in terms of prophylaxis. So how to use in our modalities in EORTC, MSG, especially in immunocompromised?
Yeah, that's a great question. A very good point. So you're absolutely right. So we already know there's a problem with specificity and sensitivity for these tests. It's even worse if you're already on anti-mold prophylaxis. So galactomannan, for example, has got a sensitivity of, depends which study you look at, but it's around 80%, which is not great, but it's not bad. If you're on mold, anti-mold prophylaxis like posaconazole, that drops down to about 50%. That's like tossing a coin. So it's almost useless. And that's exactly why when we're doing this study of galactomannan and beta-D-glucan surveillance, the options was either prophylaxis or no prophylaxis and surveillance, because it doesn't really work together, because you're absolutely right. If you're already on a mold prophylactic, those tests are not going to be helpful.
Precisely, and that's the question, that is the negative predictive value, which is a game changer. I mean, for the pneumocystis, we do consider that. But what about the other molds and all?
Very difficult because, again, both sensitivity and specificity are limited. So we get false positive and false negative. So unfortunately, we always want tests. Do we think, is this a rule-in test or rule-out test? Unfortunately, these are neither, because we get lots of false positives and lots of false negatives. And it's really, one way I described it once, think about like a C-reactive protein, for example. We don't diagnose anything just on the basis of a CRP. It's part of a package of information. It can help us with the overall package, but you wouldn't diagnose, okay, pneumonia based on a CRP, because it can go up in lots of things. It adds to the package of information which you have to assess. It's not a good enough test on its own to diagnose an invasive fungal infection. And, I think that's what's really important. The interpretation of those tests is so important. The interpretation is difficult for us as ID specialists. So when people order it who are not experienced with the test, really, I would think probably struggle to interpret it. And You always think whenever you order a test, think to yourself, what am I going to do with this result? Because you've got to put it in the context of how immunosuppressed are they? Are they on mold prophylaxis? What's the sensitivity? What's the specificity? They're very, very imperfect tests. And I'm sure you've had the experience of being consulted for a positive or a negative, and you have to weigh all these things up to figure out what it means. So yeah, they're not easy tests. I think they can be used in the right setting as part of a package of information, not on their own.
I agree. So I think the message is loud and clear. Pre-test probability has to be defined, and pre-test probability is actually a driver for taking those into the consideration. Right. So
Absolutely.
just to add on to it, there are a lot of times being queries. I mean, of course, as an ID, we receive a lot of queries. The bronchoscopy lavage, the bile galactomannan, how sacrosanct that value of 1 is. Because many a times the aspergillus are colonizers as well, especially again in the same settings of the patients I'm talking. So more than 1, of course, you always have a pre-test probability in those group of patients who are already on the mold prophylaxis, some ground glassing and some central lobular nodules. As you mentioned, that radiology is also not very typical in these set of patients. So how is the add-on of bile galactomannan to these groups?
That's a really good question as well. So yeah, it's a useful test getting a bronchial alveolar lavage, certainly. So if the sensitivity of galactomannan in serum is about 80%, it goes up to about 90% on BAL. Also, the negative predictive value of a negative BAL galactomannan is in the region of 90%. So it is better than serum. So it is useful. It's still not perfect. And you're absolutely right. We know that we get colonization of the airways with aspergillus, and that can give you a not a false positive, a positive galactomannan. It doesn't mean you've got invasive disease. So it's a step up from serum. It's not perfect. One of the problems we have, and I don't know how it is in your setting, is it's actually quite difficult for us to get BALs for these patients. So I'm not trained to do them. So we rely on our respiratory medicine colleagues to do them. And we often have this paradox where sometimes we consult the patient, the respiratory, and we say, can you do a BAL? And they say, no, the patient is absolutely fine. It's working. Well, you don't need it. Just keep treating. Or they say, no, the patient is far too sick. They can't tolerate a BAL. So we need to find that sweet spot in the middle where they'll get them to agree to do it. And often that's very, very difficult. So we have trouble getting BAL. If you can get it, it is useful because not only is the galactomannan useful and better than serum, we can also do an aspergillus PCR on that BAL. We can do a PCP PCR on that BAL. We can do cytology and culture. So we can do a lot of things on that test if we can get it. So it's definitely useful.
Absolutely. The another catch and caveat is always the platelet counts, because that's another.
Absolutely.
Right.
Yeah, whether they can tolerate it. Yeah.
True. So in the bronchoscopy only, sir, what about the multiplex PCR? Because right now we are using a lot of syndromic approaches. So in the multiplex PCR, the presence of aspergillus PCR, mucorales PCR, as you were mentioning, that there is no typical diagnostic driven modality in the mucorales, but these days a lot of tests are coming up with, these kind of mucorales PCR or aspergillus PCR. How good or bad they are to fix into this?
So there are various tests out there. So some of, the key thing is that the microbiology lab validates and verifies them properly, and there's robust data behind them. What tends to happen is the more different targets you have in a multiplex PCR, the sensitivity actually drops. It's usually much better if you have a particular target. I think they can be very useful. I think Aspergillus PCR is useful, but again, with these molecular tests, particularly with Aspergillus, you have to think, well, is it just colonization of the airway, number one? It doesn't tell you about infection and doesn't tell you about susceptibility. I think mucorales would be useful. So we don't have access to that yet. If there are mucorales PCR available on BL, it's useful because in a highly immunosuppressed patient who's doing badly and you detect mucorales there, you're probably going to treat for that. So yes, the answer is useful, but they have to be validated. It has to be, quality control has to be there as well as the interpretation. And that the more targets you have, you lose sensitivity and you might have colonization. But yes, definitely can be useful in the absence of other useful tests.
Right. So I think moving on to the prophylaxis side, two important questions, rather three, I would say. Voriconazole versus posaconazole. I mean, the age-old question, but yeah.
So our particular center, we don't use very much voriconazole. And that's because historically we've had a lot of problems with toxicities and interactions. So particularly in the hemato-oncology population who are on chemotherapy agents, polypharmacy, it's got many, many drug-drug interactions. It's also got very, very unpredictable pharmacokinetics. So drug level monitoring is absolutely essential. And that's often even, number one is having access to the test, even if it is, clinicians are quite bad at ordering it in a systematic way. So I've had many times, particularly with Vori, where I've had a consult and they say, this patient is on Vori and they're not improving. The Vori is not working. I say, do a level and it's undetectable. So they're not actually effectively on Vori. It's really critical. So we find that a very difficult drug. Posaconazole, I find much better in that sense. Yes, you need level monitoring. There are interactions, but far fewer than Vori. So in our patient cohort, we certainly favor posaconazole, especially now as it's generically made and it's not that expensive relatively. It used to be extremely expensive, but particularly again in India, India is the world capital of generic pharmaceuticals, right? So you probably have quite good access to Posa at a reasonable price. So I generally prefer that over Vori for those reasons.
Right. Though the OD price is still quite lower than the posaconazole in our setting, sir. So that's one driving factor, I would say. We are also using therapeutic drug monitoring at our center, and we have found, as you rightly mentioned, the subtherapeutic levels, both in actually Vori and posaconazole. Sometimes the timing of the administration of antifungal is also what really matters. Moving on in the same category, the isavuconazole. Considering a lot of good ideal scenarios with isavu, is it really a win-win situation in terms of the prophylaxis?
The prophylaxis, there's not much data on prophylaxis. So I think there are some studies. I've heard anecdotally of quite a few breakthroughs on isavuconazole. Why that is, I'm not quite sure. There's some little bit of skepticism, for example, in some centers in the United States who have access to it. So I think we need to get a little bit more data to reassure us about prophylaxis. Also, given the cost differential, it's much more expensive than the others. So as a prophylactic, I would use Posa or Vori. I think there was a treatment option for those special circumstances that, like I mentioned, like QT interval prolongation, super useful in that setting. And also the beauty is that we don't need to do TDM for it. We can do it. You can get an isavuconazole level if you need. But I have to say, every time I've ever tested it, the level has been absolutely fine. It's got very predictable linear pharmacokinetics, far fewer drug interactions and absorption problems than the others. So I think it's got a lot of attractive qualities. If they were all absolutely at equal cost, I would use a lot more isavuconazole than the others. But it's still it's more difficult to access. Do you have good access to isavuconazole? Is it something which is an option for you? Are you able to access it?
So isavuconazole, as you have mentioned, the innovator brand is still there, but it is little out of the league in terms of the prices. As you said, the generic part, we have come across the 3 or 4 new generic brands of isavuconazole. But again, the question is the access to the TDM is not so homogeneous that the questionability about the brand and their levels is still something to be considered.
An issue. Yeah, absolutely.
So one of our pediatric hematologists, Dr. Swati, she wants to ask you that what is the best antifungal prophylaxis, especially in the ALL patients, especially when we know about the typical drug interaction with the kids?
So that's a great question. So first, I would say I'm an adult physician, so I don't deal much on the pediatric side, but I'm aware, particularly in ALL, this is an issue. And there's 2 issues in ALL prophylaxis. One is certainly there are a lot of drugs involved, which interact with the azoles and makes them not possible. Vincristine, for example. So that's one problem. Also, the rates of fungal infection in ALL in kids are actually particularly lower than, for example, adults with AML. And some centers favor not using antifungal prophylaxis at all because of the interactions and because we don't see that many fungal infection. So there's no ideal prophylactic because if you can't use azoles, then we're talking about, as I mentioned, the kind of echinocandins or liposomal amphotericin B, which is IV and difficult. So certainly some centers are favoring an ALL to the surveillance approach that we don't give prophylaxis, but obviously have a low threshold for imaging and doing fungal biomarkers and so on. But certainly that's a tricky area, and I'm aware of the azole interaction. So there's no perfect answer. But in our center, the pediatric hematologists have moved away from prophylaxis at all and are happy to do surveillance because they feel they see very few fungal infections in that particular cohort.
Right, and considering the fact the concomitant hepatotoxicity of both the drugs as well as the azoles, that's a question.
It's a real issue. Yeah.
Right. Moving on, sir, how you put echinocandin into the same perspective in terms of prophylaxis, I'm asking.
Yeah, so prophylaxis, most centers don't use echinocandins as prophylaxis. There are some places which do in the United States, for example. Again, it's a cost and an IV issue. We do use it in some cases where the patient is unable to tolerate azoles, but then we've got this problem. It's a once daily IV infusion, which is not a great modality for a prophylactic drug. So amphotericin B ambisome, for example, sometimes we use that for prophylaxis when there are other options. The good thing about the pharmacokinetics of that with liposomal amphotericin B, it stays around in tissues for a long time. So it's very amenable to, say, twice weekly dosing. What I think will change matters is this new echinocandin resofungin. It's once weekly. That's really going to be very useful. I think it might change the landscape for prophylaxis. And in fact, we are a clinical trial site for something called the RESPECT trial, which is a clinical trial of resofungin as prophylaxis and stem cell transplant. So I think once that data comes out, if it's positive, that might become a really useful option going forward as a prophylactic option, because once weekly is very useful for some patients.
Very true. Once weekly, no need of TDM. I think a good strategy. So one very pertinent question, sir. Combination antifungal in the immunocompromised setting. Especially because many a times, especially in the post-kidney transplant, and whenever there is a fluid overload issues, a lot of people have this query that azole plus echinocandin is equivalent to an amphotericin B. So is this kind of combination good and upfront combination of the antifungals?
This comes up a lot about combination antifungal therapy. I see it used a lot, mainly because the patient is deteriorating and people are worried. The bottom line is there is no good randomized trial data that shows that two antifungals are better than one. It doesn't exist, with the exception of Cryptococcus. So we know that Ampho B plus flucytosine is better than Ampho B alone. That's the only example where we have proven data which shows the combination therapy is better. So most of the time, using combination antifungals actually just gives the patient more toxicity and more cost and drives more resistance. Yes, of course, in individual cases, if they're not responding, it's refractory salvage therapy, you might go for dual antifungals, but not routinely because the data just isn't there to support it, except for Cryptococcus.
Understood. That's true. That's true. But the only idea about that, is there any role for the salvage or refractory? Like we used to learn in the mucormycosis, but not the upfront combination in most of the patients.
Not
Right.
upfront. So yeah, mucormycosis, again, because there's very poor data on mucormycosis and because it's so rapid and so destructive, often we do use combination therapy. Just because things are so bleak clinically, we often use Ampho B or ambisome plus ivacavconazole because it progresses so rapidly. There's not great data behind it, but I understand why most people do it because things often go out of control very quickly.
True. I agree. It's more of, I would say, an anticipation and apprehension based rather than the evidence based.
So what I normally say to people with mucor, I say start on ambisome high dose. If it progresses, add an isavuconazole, and of course it always progresses. So the next day I see them on both, which is understandable from a clinician point of view.
That's absolutely true. One very important question is that there are a lot of heterogeneous practices in hematopoietic stem cell transplant regarding the duration of antifungals. So considering the fact that the T cell has started coming up, so what's the usual practice? Do you do at day 60 or you want to continue till the cyclosporin continues? I mean, the your center guidelines, just to highlight us.
Yeah, so it's a golden question, right? It's one of the big black holes of data. I get asked all the time about duration. We just do not know how long to give it for. I get asked that all the time, and it's so patient dependent. Are they better? Is the CT scan better? Is the immunosuppression down? Have they got neutrophils? It's really patient by patient. I think in my head of kind of 6-week blocks. So I'm going to review it at 6 weeks. Let's look at everything. Most patients have to continue. Then you go to 12 weeks. And it's such a variety. We desperately need studies because there is no good answer. It's so individualized. So yeah, definitely a big hole in our data. So when people ask me, how long do you give antifungal for? And I just say it depends on the patient. I can't tell you a number.
Absolutely. So I think in the best interest of the time and knowing the fact, thank you so much, Dr. Neil, for being a part of this forum. And as you said, future holds for fungal, definitely, and had really fun with the fungal guy out there. So thank you all for being there on the net. And thank you, Dr. Neil, once again for being a patient listener and a great speaker as you always are. So thank you all. And we'll be coming back with the next month series on the same forum. And stay tuned. Thank you.
Thank you very much. It was a great pleasure.
Thank you. Thank you so much.